let's start with absolute important revision for endo and pedo. We have just 6 days left for our main exam. I hope you are completing the daily targets, solving the previous year questions, and revising subjects daily. Watch these videos along with the notes and revise these videos and the notes again and again because these will help you in your final exam. So let's start. Let's start with the radiographic image-based question. So we have this tooth with this radiolucency present. So it's a J-shaped radiolucency which is seen in vertical root fracture. Then a very important question comes from vertical root fracture or crack is that modified IOWA staging is used to check the cracked teeth. Modified IOWA staging is used to check the cracked teeth. Then we have this image. So guys, what is this? Here we can see that the pulp stage has enlarged. So what is this? This is internal resorption. So guys, how will you differentiate between external inflammatory resorption and external replacement resorption? So for example, we have this tooth. So in external inflammatory resorption, you will see the radiolucent areas like this on the border. Whereas in external replacement resorption, what we will see that the PDL space is not there and the tooth is moving towards ankylosis. So in external inflammatory resorption, we will see radiolucent areas. Whereas in external replacement resorption, what you will see, for example, this is the bone. So what will you see? That this space is not there and the tooth is moving towards ankylosis. So this is external inflammatory resorption and this is external replacement resorption. Guys, make note of these three image-based questions. These are highly important. Now let's see some questions. So internal transportation of canal is what? So it is ledge. And irreversible pulpitis earliest marker is calcitonin gene related peptide. Now let's move forward. So we have the Ellis and Davis classification. It's a very simple classification, but you guys make lots of mistake from it. So let's see it once again. So in Ellis class 1 fracture, we have the fracture of enamel. It's simple. We have fracture of enamel. Then in Ellis class 2, there is fracture of enamel as well as the dentine. Now Ellis class 3, there is pulpal involvement, fracture of enamel, dentine as well as the pulp. Now guys, please make a note of the Ellis class 4 fracture. In this, the tooth has become non-vital. So for example, you are given this question, somewhat like this, tooth is there. And here you can see some pulpal exposure also here. So guys, don't mark this as Ellis class 3 straight away. Check the discoloration of the tooth. If the tooth is being shown as discolored, then mark this as Ellis class 4 because the examiner wants to know that discolored tooth, that is a necrotic tooth, that is a non-vital tooth, that is Ellis class 4. Then we have Ellis class 5. So basically, it is a case of avulsion. Then we have Ellis class 6. So in Ellis class 6, we have root fracture. Then in Ellis class 7, we have the displacement of the tooth. Ellis class 8, we have crown in mass fracture. And Ellis class 9 are any fractures related to the deciduous tooth. So how will we remember this? Class 1 enamel, class 2 with dentine, class 3 pulp. Then we will remember this as NARD. That is non-vital is 4, avulsion is 5, root fracture is 6, displacement is 7, and crown in mass is 8, and all the fractures governing the deciduous teeth are 9. Let's move forward. So we come to traumatology and the IADT guidelines. These are very, very important. Expect 1 to 2 questions at least from this. So let's start. So first of all, minimum number of X-rays in traumatic dental injury are, so they are 4. Whenever there's a traumatic dental injury, you have to take 4 number of X-rays. How? So one is taken at 90 degree, two are taken at different vertical angles, that is 45 degree and 110 degree. And the fourth X-ray is a occlusal. So we have 90 degree, two vertical angulations, 45 degree, 110, and fourth is the occlusal. Then we come to different specific management. So for example, if we are giving Ellis class 1 or class 2, so what does the IADT guideline say? So IADT guideline says that hydrate the fragment for 20 minutes in saline. Guys, make note of this, 20 minutes in saline. And if fracture close to pulp, then put calcium hydroxide as liner. If fracture is close to pulp, then give a calcium hydroxide liner. Then we come to Ellis class 3 fracture. So it has different protocols. So if the fracture has been done less than 24 hours, so what we will do? We will do pulp capping procedure. If fracture is less than 24 hours old, we will do pulp capping procedure. If it is less than 72 hours, what we will do? We will do Schweck pulpotomy. We will do Schweck pulpotomy. And if it is more than 72 hours, what we will do? We will do pulpotomy. And longer than that, then we will have to do a complete RCT or a pulpectomy. Then Schweck pulpotomy, a very important question comes, that most important prognostic factor while doing Schweck pulpotomy is what? So it is the extent of inflammation of the pulp. So it is the most important prognostic factor when doing Schweck pulpotomy. Then we come to root fracture. So if the coronal fragment is mobile, coronal fragment mobile, then we will splint it up to 4 weeks. We have to splint it up to 4 weeks. So whenever there is a fracture occurring, we have a coronal fragment and the apical fragment. So the coronal fragment will become necrotic with time. So we have to do RCT of the coronal fragment. Then third case scenario becomes, if the coronal fragment is mobile and it is more cervically placed. For example, this is the tooth and we have a fracture around here. So what we will do, we will extract the coronal fragment and we will remove the coronal fragment and do the RCT of the tooth. So we will remove this coronal fragment, remove coronal fragment, do RCT and followed by post and code, followed by post and code. Then when there is alveolar bone fracture, what we will give? We give a flexible splint. Guys, note this. Whenever we are splinting, we are doing it flexibly. In root fracture also, we give a flexible splint. So in alveolar bone fracture, we will give a flexible splint for 4 weeks. Then in concussion, no treatment is required. Then coming to subluxation. So again, we give a flexible splint for 2 weeks. Then guys, what will we do for extrusive luxation? So again, we give a flexible splint for 2 weeks. Then lateral luxation, we give a flexible splint for 4 weeks. Guys, note the time in every case scenario. It's very, very important. So root fracture, we are doing for 4 weeks. alveolar bone fracture, 4 weeks, lateral luxation, 4 weeks. Note these time periods, very, very important. Then subluxation, 2 weeks, extrusive luxation, 2 weeks. Moving forward, we come to intrusion. So when the intrusion is less than 3 mm, we will allow the tooth to come back in position within 8 weeks. If the tooth is not coming back in position, we bring the tooth back in position and will give a flexible splint for 4 weeks. So we will allow the tooth to reposition and we will wait for a period of 8 weeks. If it's not happening, we will put a flexible splint for 4 weeks. Then if the intrusion is 3 to 7 mm, what we'll do? We'll do a ortho or a surgical extrusion. If more than 7 mm extrusion is there, what we will do? We will do a surgical extrusion. So we will do a surgical extrusion. Then guys, we come to case of avulsion. So when it's delayed, or immediate reimplantation, we give a splint for 2 weeks. In either of the two cases, we will give a splint of 2 weeks. But guys, note it, very important. When there is alveolar bone fracture, we will give for 4 weeks. So in which all cases we are going for 4 weeks? So in intrusion, 4 weeks, alveolar bone fracture, 4 weeks, then lateral luxation, 4 weeks, and root fracture, 4 weeks. Rest all we give for 2 weeks. So in avulsion, when extraoral time is less than 60 minutes and we have a closed apex, we will treat the tooth by saline. And when there is open apex, we can treat the tooth by doxy or minocycline for a period of 5 minutes. So if extraoral time is more than 60 minutes and if it's closed or open apex, in both cases, we will remove the PDL removed by citric acid, which is 3% in concentration for a period of 5 minutes. Guys, remember these values. These are very, very important. How much concentration of citric acid is being used for how much time? 5 minutes, 3% citric acid. We are removing the PDL. And any endodontic intervention in either of these cases, we will do after 2 weeks. Any endodontic intervention we will do after 2 weeks. Then we come to IADT guidelines for the primary teeth. So in first to fifth case, that is till concussion. For primary teeth, we will follow the same protocol. Primary teeth, same protocol as permanent teeth. Subluxation in a primary tooth, no treatment is required. Then for extrusive luxation, if tooth not interfering in occlusion, let tooth reposition. Let tooth reposition. Then if a primary tooth comes with lateral luxation, what we will do? So if the tooth is mobile or extruded more than 3 mm, we will extract the tooth. Or otherwise, what we can do? We can splint tooth for 4 weeks. We can splint the tooth for 4 weeks. Then we come to intrusion. For a primary tooth, we will allow spontaneous repositioning. We will allow spontaneous repositioning. Very important question. What will we do in case of avulsion of a primary tooth? So you don't re-implant the tooth. Guys, very important question. Came in NEET MDS 2026 also. You will not re-implant the tooth. Whenever examiner is asking you a question, check the age. For example, if 5-year-old patient anterior tooth got avulsed, So he is talking about a deciduous tooth because in 5-year-old patient, anterior permanent has not come. So you won't reimplant the tooth. You will not reimplant the tooth. Another important question, most common traumatic injury in child. So we have concussion is the most common, followed by subluxation, then luxation, and in luxation, what we have the intrusion. So guys, these were the important or the AIR questions from Endo and Pedo. What you guys have to do, you have to cover Heller classification of dens and dente, then the Heatherse classification of cervical resorption, child psychology, IQ scoring, NOLA stages. Endo files I have covered in my Q&A video. Also go back to the AIR visuals video and see the image-based questions from both these subjects. So guys, keep working hard, keep studying, keep revising all these videos, and all the best for your preparation.